Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. The advent of cellular and gene therapies, CGT, especially chimeric antigen receptor, CAR, T-cell therapies, has fundamentally changed the way hematologic malignancies are treated, offering unmatched effectiveness. However, this strong immune activation often leads to unique and potentially life-threatening toxicities, most notably cytokine release syndrome, CRS, and immune effector cell-associated neurotoxicity syndrome, ICANS. CRS is described as an acute, systemic inflammatory response caused by the powerful, targeted immune reaction, while ICANS is a separate, complex neuropsychiatric disorder frequently triggered by the inflammatory environment of CRS. Effective clinical management depends on a thorough understanding of the distinct yet interconnected pathophysiology of these syndromes. This clinical guidance module provides the essential framework for safe and effective care, highlighting a standardized approach to toxicity triage and intervention. This framework involves the formal adoption of the American Society for Transplantation and Cellular Therapy, (STCT), consensus grading criteria for consistent assessment, proactive surveillance using tools like the Immune Effector Cell-Associated Encephalopathy (IC) score, and the implementation of a Specialized Rapid Response System (RRS). Importantly, the system relies on the use of standardized order sets (SOS) to ensure the timely and consistent delivery of grade-specific pharmacotherapies, such as tocilizumab and corticosteroids, reducing risk and improving patient safety in this high-acuity environment. As experts in clinical practice and pharmaceutical management, a comprehensive understanding of cellular therapy toxicities is essential for ensuring patient safety. Upon completing this educational module, participants will be able to demonstrate competence in several key areas. They will learn to differentiate between the pathophysiology of cytokine release syndrome, an acute systemic inflammatory response, and neurotoxicity associated with immune effector cells, which is a distinct neuropsychiatric disorder. Participants will understand the mechanisms underlying cytokine release syndrome, specifically the roles of activated myeloid cells, such as macrophages and monocytes, and the significance of cytokines like interleukin-6 in mediating systemic inflammation. This biological insight provides the foundation for targeted therapeutic interventions. The relationship between systemic cytokinic inflammatory responses and neurotoxicity will be emphasized, particularly how systemic inflammation can compromise the blood-brain barrier, allowing inflammatory mediators to enter the central nervous system. Furthermore, participants will learn to apply grading criteria established by a leading professional society to assess the severity of cytokine release syndrome accurately. This involves evaluating clinical parameters such as fever, low blood pressure, and low oxygen levels. Participants will also become proficient in employing a standardized scoring system designed to monitor cognitive decline. This score is vital for the early detection of neurotoxicity. Recognizing the importance of rapid response systems, learners will be able to identify triggers for activating specialized response teams based on physiological signs and the severity of symptoms. In terms of pharmacotherapy, participants will learn to select appropriate first-line treatments for cytokine release syndrome, such as specific immune-modulating drugs and corticosteroids, adjusting interventions according to the severity of the syndrome. Managing neurotoxicity will involve initiating high doses of corticosteroids when indicated and understanding why certain medications, like interleukin-6 inhibitors, are typically not recommended for isolated neurotoxicity cases. Lastly, learners will be equipped to develop integrated treatment plans for cases where both syndromes occur simultaneously. This will include prioritizing immediate corticosteroid therapy while addressing the systemic inflammatory response. Additionally, participants will be encouraged to advocate for standardized, multidisciplinary protocols to ensure timely and consistent administration of treatments tailored to syndrome severity. The emergence of cellular and gene therapies, CGT, especially chimeric antigen receptor, CAR, T-cell therapies, marks a major shift in treating blood cancers. These therapies utilize the patient's immune system to target and destroy cancer cells with remarkable effectiveness. However, this powerful immune response can also cause serious and sometimes life-threatening side effects. The two most common and serious issues are cytokine release syndrome, CRS, and immune effector cell-associated neurotoxicity syndrome, ICANS. A thorough understanding of the different but related mechanisms behind these syndromes is essential for safe and effective treatment. Cytokine release syndrome is an acute, systemic inflammatory response that occurs as a direct, targeted consequence of the immune-activating agent's therapeutic mechanism. The American Society for Transplantation and Cellular Therapy, ASTCT, defines CRS as a supraphysiologic response following any immune therapy that results in the activation or engagement of endogenous or infused T cells and/or other immune effector cells. 6. It is not an unexpected side effect, but rather a result of the intended, potent immune response triggered by the therapy. The pathophysiological process starts when engineered T cells, such as CAR T cells, recognize and bind to their target antigen on tumor cells. This binding prompts strong T-cell activation, proliferation, and the execution of cytotoxic actions, which lead to cancer cell death. This can induce a specific type of inflammatory cell death called pyroptosis, resulting in the release of damage-associated molecular patterns, DAMPs, and pro-inflammatory mediators from the dying tumor cells. This initial release acts as a significant danger signal, sparking a self-amplifying inflammatory loop. This signal activates nearby immune cells, especially macrophages and monocytes, which are recruited to the inflammation site. These activated myeloid cells, rather than the CAR T cells themselves, become the main source of the large, systemic cytokine release that defines the syndrome. This distinction is crucial because it explains why therapies targeting myeloid-derived cytokines are so effective in managing CRS. The cytokine profile of CRS is intricate and involves a wide range of inflammatory mediators. Key cytokines implicated include interleukin-6, IL-6, interferon gamma, IFN-gamma, tumor necrosis factor alpha, TNF-alpha, interleukin-1, IL-1, and granulocyte macrophage colony stimulating factor, GM-CSF7. Among these, IL-6 is identified as a central driver of CRS pathology. Elevated IL-6 levels strongly correlate with CRS severity and are responsible for many of its hallmark clinical features, such as fever, tachycardia, and the production of C-reactive protein, CRP, by the liver. Furthermore, IL-6 contributes to endothelial activation and increased vascular permeability, which leads to the dangerous capillary leak syndrome seen in severe CRS. 9. This central role of IL-6 supports the use of tocilizumab, a monoclonal antibody that blocks the IL-6 receptor, IL-6R, as the main targeted therapy for moderate to severe CRS. The clinical signs and symptoms of CRS present in a progressive spectrum. The key, defining feature at onset is fever, which is a temperature of 38 degrees Celsius, 100.4 degrees Fahrenheit, or higher, not caused by other factors. Common associated constitutional symptoms include fatigue, headache, myalgias, and nausea. As the syndrome worsens, evidence of end-organ dysfunction appears, driven by systemic inflammation and capillary leak. Cardiovascular signs such as tachycardia and hypotension may develop, potentially leading to shock requiring vasopressors. Respiratory issues can present as hypoxia, which may develop into pulmonary edema and acute respiratory distress syndrome, ERDS, necessitating high-flow oxygen or mechanical ventilation. In its most severe form, CRS can resemble other hyperinflammatory conditions like macrophage activation syndrome, MAS, or hemophagocytic lymphohistiocytosis, HLH, characterized by extreme hyperferritinemia, cytopenias, coagulopathy, including DC, and multi-organ failure affecting the heart, kidneys, and liver. Several factors are associated with an increased risk of developing severe CRS. These include high tumor burden at the time of cell infusion, certain patient comorbidities, and specific characteristics of the therapeutic product itself. For instance, CAR T-cell constructs that utilize a CD28 costimulatory domain are often associated with more rapid T-cell expansion and a higher incidence of severe, early-onset toxicities compared to those with a 4-1BB domain. The onset of CRS is typically acute, most often occurring within the first 14 days following cell infusion, with a peak incidence within the first week. Immune effector cell-associated neurotoxicity syndrome is a distinct and complex neuropsychiatric disorder that can occur following immune effector cell therapies. The American Society for Transplantation and Cellular Therapy formally defines this condition as a disorder characterized by a pathological process involving the central nervous system after any immune therapy that results in the activation or engagement of endogenous or infused T cells and other immune effector cells. The exact mechanisms underlying this syndrome are still under active investigation. However, it is understood to be a multifactorial condition that is different from cytokine release syndrome. A leading hypothesis suggests that the systemic inflammatory environment created during CRS is a key initiating factor. Elevated levels of circulating cytokines cause widespread activation of endothelial cells throughout the body, including the blood vessels of the central nervous system. This activation damages the blood-brain barrier, BBB, making it more permeable. As a result, inflammatory cytokines and peripheral immune cells, such as monocytes and T cells, can enter the CNS parenchyma, an area that is normally immune-privileged. Once inside the CNS, these elements induce a secondary, localized inflammatory response involving CNS-resident cells, such as microglia, astrocytes, and parasites. Recent preclinical evidence highlights a crucial role for microglial activation through the TGF-beta-activated kinase 1, TK1, and P38-MAPK signaling pathways in causing neuronal dysfunction associated with ICANS. This CNS-specific inflammatory process, rather than direct neurotoxicity from CAR T cells, is believed to be the main cause of the syndrome's clinical features. ICANS usually presents as a toxic encephalopathic state with a wide range of possible symptoms. The initial signs can be subtle, making prompt recognition by frontline clinicians crucial. These early indicators often include reduced attention, expressive aphasia, especially word-finding difficulty or anomia, tremor, and dysgraphia, a decline in writing ability. If untreated, these early signs can quickly worsen into more severe and widespread neurological deficits. These may include global aphasia, significant changes in consciousness levels, from drowsiness to coma, motor weakness, and seizures, which can be focal, generalized, or non-convulsive, status epilepticus. An important and often characteristic finding on examination is a patient who is alert and awake but mute or unable to follow commands, helping to distinguish ICANS from the sedative effect. The most serious and life-threatening complication of ICANS is cerebral edema, which causes increased intracranial pressure, ICP, and can lead to brain herniation and death. A strong clinical link exists between CRS and ICANS. ICANS often occurs alongside or, more frequently, after CRS resolves. Developing early and severe CRS is one of the key risk factors for later high-grade ICANS. This suggests that systemic inflammation from CRS may prime the CNS for neurotoxicity. However, it is important to note that ICANS can also occur without prior or simultaneous CRS, indicating that other mechanisms independent of CRS may also be involved. The typical onset of ICANS is around 4 to 5 days after cell infusion, often as CRS symptoms begin to decrease. However, the risk window is broad, and delayed onset icons has been observed in some patients more than 3 weeks after infusion. The connection between these two syndromes is essential for clinical practice. The systemic inflammatory process in CRS seems to be a necessary precursor in many cases of icons, inducing endothelial activation that disrupts the blood-brain barrier. This disruption allows for the development of a localized CNS inflammatory process, which directly causes neurologic symptoms. This sequence suggests that prompt and aggressive management of CRS may not only alleviate systemic symptoms, but also serve as a key approach to reducing the risk and severity of subsequent, often more serious, neurotoxicity. The effective management of CRS and icons is predicated on the ability of clinical teams to accurately and reproducibly assess and grade their severity. Subjective clinical impressions are insufficient to guide the use of potent immunomodulatory therapies. The development and widespread adoption of the ASTCT consensus grading criteria have been essential in standardizing the evaluation of these toxicities, thereby facilitating the creation of evidence-based management algorithms and allowing for meaningful comparison of toxicity profiles across different therapies and institutions. The ASTCT consensus criteria provide a simplified yet robust framework for grading CRS severity. The grade is determined by the most severe manifestation across 3 core clinical parameters, all of which must not be attributable to any other underlying cause, for example, septic shock, cardiogenic pulmonary edema. This system provides an objective basis for escalating care. The core grading parameters for diagnosing cytokine release syndrome include several key factors. Fever is a primary indicator, with a temperature exceeding 38 degrees Celsius or 100.4 degrees Fahrenheit, serving as a prerequisite for the initial diagnosis. Hypotension, or low blood pressure, is evaluated based on the level of hemodynamic instability, which is assessed by the need for intravenous fluids or support with medications that constrict blood vessels. Hypoxia, indicating respiratory compromise, is determined by the requirement for supplemental oxygen and the mode of its delivery. These parameters collectively help in accurately assessing and grading the severity of the syndrome. Critical nuance in the application of these criteria is that once a patient with CRS receives anticytokine therapy, for example, tocilizumab, or corticosteroids, the presence of fever is no longer required to grade the ongoing severity of the syndrome. This is a crucial clinical point, as it prevents the premature de-escalation of care or misclassification of a patient who remains afebrile due to treatment but continues to require significant hemodynamic or respiratory support. This ensures that the grading accurately reflects the patient's true physiological state. The assessment of icons is inherently more complex than that of CRS due to the multifaceted nature of neurological function. The ASTCT grading system for icons addresses this by incorporating a multi-domain assessment. The final grade is determined by the single most severe finding across 5 distinct neurological domains. This comprehensive approach ensures that subtle but significant changes, such as a decline in cognitive function, are given equal weight to more overt signs like seizures. Here's a detailed explanation of the grading system for cytokine release syndrome. Grade 1 is characterized by the presence of fever with a temperature exceeding 38 degrees Celsius. At this stage, there is no hypotension or hypoxia. In Grade 2, the patient still has a fever over 38 degrees Celsius. Hypotension does not require vasopressor medications but responds to fluid treatment, and hypoxia demands the use of a low-flow nasal cannula delivering less than 6 liters per minute of oxygen. Grade 3 involves a fever higher than 38 degrees Celsius, with hypotension necessitating a single vasopressor medication, which may include vasopressin. Hypoxia at this stage requires high-flow nasal cannula delivering more than 6 liters per minute, or the use of face masks, non-rebreather masks, or Venturi masks. In Grade 4, the fever persists with a temperature above 38 degrees Celsius. Hypotension requires multiple vasopressor medications, excluding vasopressin, and hypoxia requires positive pressure ventilation, such as continuous positive airway pressure, bilevel positive airway pressure, or intubation with mechanical ventilation. This grading system is adapted from a study by Lee and colleagues published in the Biology of Blood and Marrow Transplantation in 2019. The final grade assigned to cytokine release syndrome depends on whether hypotension or hypoxia is more severe. While the presence of fever is necessary for the initial diagnosis, it is not required for grading the severity once treatment with medications to reduce fever or cytokine levels has been administered. It is also important to note that hypotension and hypoxia should not be attributed to any other underlying causes. The cornerstone of objective assessment for immune effector cell-associated encephalopathy is the 10-point immune effector cell-associated encephalopathy score. This simple and validated screening tool is designed for quick bedside use to detect subtle changes in cognitive function. It is crucial that the score be assessed proactively and regularly, at least twice daily, for all patients at risk. A decline in the score is often the earliest sign of developing immune effector cell-associated encephalopathy. The assessment includes several components. First, the patient's orientation is evaluated by asking for the current year, month, city, and hospital. The patient receives 1 point for each correct answer, with a maximum of 4 points. Next, the patient is asked to name 3 common objects in the room, such as a pen, clock, or button, with 1 point awarded for each correctly named object, up to a maximum of 3 points. The assessment also involves testing the patient's ability to follow simple commands, for example, asking them to close their eyes and stick out their tongue. If the patient can follow the command, 1 point is awarded. The writing component requires the patient to write a standard, dictated sentence, such as, "Our national bird is the bald eagle." The patient receives 1 point if they can produce a legible and sensible sentence. Additionally, the patient's attention is evaluated by asking them to count backwards from 100 by tens. If they can complete this task without significant errors, they earn 1 point. The total possible score on this assessment is 10. A score of 10 indicates normal neurological function, while a score of 0 suggests that the patient is unarousable and cannot be tested. This assessment methodology has been adapted from a publication by Lee and colleagues in 2019, which highlights its effectiveness in early detection of immune effector cell-associated encephalopathy. The final grading of immune effector cell-associated neurotoxicity syndrome is determined by the most severe event across any of the 5 domains. The American Society for Transplantation and Cellular Therapy has established a consensus grading criteria for this syndrome. These criteria include the grade, immune effector cell-associated neurotoxicity syndrome score, level of consciousness, seizures, motor findings, and elevated intracranial pressure or cerebral edema. For grade 1, the immune effector cell-associated neurotoxicity syndrome score ranges from 7 to 9. Patients are able to awaken spontaneously, and there are no seizures, motor findings, or elevated intracranial pressure or cerebral edema. In grade 2, the score ranges from 3 to 6. Patients are able to awaken to voice with no seizures, motor findings, or elevated intracranial pressure or cerebral edema. Grade 3 is characterized by a score of 0 to 2. Patients may only awaken to tactile stimuli. They may experience clinical seizures that are focal or generalized, but which resolve rapidly, or non-convulsive seizures observed on electroencephalogram that resolve with intervention. There are no motor findings, but focal or local edema may be present on neuroimaging. Grade 4 is associated with a score of 0, especially if the patient is unarousable. These patients are unarousable or require vigorous or repetitive stimuli to wake, or they are in stupor or coma. Life-threatening prolonged seizures lasting more than 5 minutes or repetitive seizures without returning to baseline may occur at this stage. Deep focal motor weakness, such as hemiparesis or paraparesis, may also be present. Signs of diffuse cerebral edema, including papilledema or Cushing's triad as observed during physical examination or imaging, or posturing such as decerebrate or decorticate posturing, may indicate elevated intracranial pressure or cerebral edema. Early detection of CRS and ICANS is crucial for preventing progression to severe, potentially life-threatening grades. This demands a structured and vigilant approach to patient monitoring. For all inpatients during the high-risk period following CGT infusion, typically the first 14 to 28 days, Vital signs should be monitored at least every 4 to 8 hours. Neurological assessments, including a formal ICE score calculation, must be performed at least twice daily and whenever there is a change in mental status. At the first sign of either syndrome, such as a new fever for CRS or a decrease in the ICE score for ICANS, monitoring frequency must be immediately increased. For Grade 1 toxicities, this may involve checking vital signs and neurological status every 2 to 4 hours. For Grade 2 or higher toxicities, monitoring should be increased to every 1 to 2 hours, and patients with Grade 2 or higher CRS need continuous cardiac telemetry and pulse oximetry to detect arrhythmias and worsening hypoxia. A baseline set of laboratory tests should be obtained before cell infusion. Post-infusion, daily laboratory monitoring should include a complete blood count, CBC, with differential, a comprehensive metabolic panel, CMP, and inflammatory markers such as C-reactive protein, CRP, and ferritin. For patients developing moderate to severe CRS, coagulation studies, including prothrombin time, PT, partial thromboplastin time, PTT, fibrinogen, and D-dimer, are essential to monitor for the development of DTC. These standardized grading systems and proactive monitoring protocols are more than just tools for documentation and research. They form the essential afferent limb of a rapid response system, RRS. An RRS framework consists of an afferent or triggering component, which identifies patient deterioration, and an efferent or response component, which is the team that intervenes. The objective criteria within the ASDCT grading systems provide the precise, unambiguous triggers needed for this afferent limb to function effectively. A drop in systolic blood pressure below 90 millimeters of mercury or a new oxygen requirement are not only definitions of Grade 2 or 3 CRS, but they are also classic, universal triggers for RRT activation. Similarly, an acute change in mental status, which is a standard RRT trigger, is precisely quantified for CGT patients by the ICE score. Therefore, a decline in the ICE score from 10 to 7, Grade 1 ICANS, or the onset of hypoxia requiring a nasal cannula, Grade 2 CRS, should be hardwired into institutional protocols as an immediate and non-negotiable trigger for RRT activation or, at a minimum, an urgent physician consultation. This approach transforms the grading tools from passive assessment instruments into active components of a dynamic patient safety system, bridging the gap between recognition and response. Upon arriving at the patient's bedside, the rapid response team must follow a standardized protocol to ensure patient safety and initiate appropriate management. The first priority is to assess and manage any life-threatening issues related to the patient's airway, breathing, or circulation. Once these immediate concerns are addressed, the team should proceed to consider a broad range of potential diagnoses, recognizing that while cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome are common in patients who have recently undergone chimeric antigen receptor T-cell therapy and present with fever or neurological changes, these are not the only possible causes. It is critical to avoid assuming these diagnoses prematurely and to conduct a thorough workup for other etiologies. For instance, infections or sepsis are common in immunosuppressed and neutropenic patients. Blood cultures should be obtained and empiric broad-spectrum antibiotics considered, especially in cases of fever related to neutropenia. Neurological symptoms may stem from various conditions, including central nervous system infections, strokes, metabolic encephalopathy, or drug toxicity. Urgent neuroimaging, such as computed tomography or magnetic resonance imaging scans, may be necessary to clarify the diagnosis. While the diagnostic evaluation is ongoing, the team should provide initial supportive care. This involves establishing reliable intravenous access, administering supplemental oxygen to maintain saturation within target ranges, providing intravenous fluids to treat hypotension, and implementing safety precautions, such as seizure precautions and measures to prevent aspiration in patients with neurotoxicity. These steps are essential to stabilize the patient and prevent further deterioration while the underlying cause is determined. The management of these rare toxicities presents challenges that may go beyond the capabilities of a generalist RRT. While standard critical care measures, fluids, oxygen, pressors, are necessary supportive steps, they are not enough to address the underlying immunopathology of CRS and ICANS. These syndromes require the prompt use of highly specific immunomodulatory agents like tocilizumab and corticosteroids, which are not typically part of a standard RRT's toolkit. Additionally, clinical decision-making is complex. For instance, administering tocilizumab for isolated ICANS is contraindicated and could worsen the patient's condition. This level of specialized knowledge indicates that institutions offering cellular therapy need to improve their rapid response capabilities. They should either provide extensive, competency-based training to upgrade their existing RRT or, preferably, establish a dedicated immuno-oncology emergency team, IOET. Such a team would consist of members with in-depth expertise in oncology, critical care, and cellular therapy, ensuring responses to these complex emergencies are both swift and precisely targeted, with the best possible guidance. Immediate priorities in managing this condition include assessing and stabilizing the airway, breathing, and circulation. It is essential to provide initial supportive care by securing intravenous access, administering supplemental oxygen, and implementing precautions to prevent seizures and aspiration. A differential diagnosis should be initiated without assumptions. It is a critical error to consider only certain conditions such as cytokine release syndrome or immune effector cell-associated neurotoxicity syndrome. Many patients are often immunosuppressed, so blood cultures should be drawn, and the use of empiric broad-spectrum antibiotics should be considered for neutropenic fever. Other neurological events, such as infections of the central nervous system, strokes, or metabolic encephalopathy, must also be considered. Urgent neuroimaging, such as computed tomography or magnetic resonance imaging, may be warranted to investigate these possibilities. It is important to recognize that standard critical care responses are insufficient to treat the underlying immunopathology. The rapid response team must be able to deploy highly specific immunomodulatory agents, such as tocilizumab and steroids, guided by the specific clinical context. For instance, administering tocilizumab should be avoided in cases of isolated neurotoxicity without systemic involvement. Standardized order sets are essential decision support tools that ensure the timely, consistent, and grade-specific administration of therapies, thereby enhancing patient safety in high-acuity situations. The development of these sets must be a multidisciplinary effort involving specialists from oncology, critical care, nursing, and pharmacy departments. A structured and evidence-based approach to treatment is essential for managing the acute and rapidly changing nature of cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. Standardized order sets are indispensable clinical decision support tools that convert complex guidelines into immediate, actionable care protocols. These order sets enhance patient safety by reducing medication errors, ensuring adherence to best practices, and streamlining workflow among physicians, nurses, and pharmacists in high-acuity scenarios. For toxicities related to cellular gene therapies, such order sets provide a critical framework for deploying intervention strategies that are specific to the severity grade in a timely and consistent manner. An effective order set for cytokine release syndrome and neurotoxicity must be comprehensive, covering all aspects of patient management from monitoring to therapeutic intervention. The development of these order sets should involve a multidisciplinary team, including experts from oncology, critical care, nursing, and pharmacy, to ensure they are both clinically sound and practical for implementation. Key components of a well-designed order set include explicitly ordered vital sign monitoring, neurological assessments such as formal neurological scores, and continuous cardiac and oxygen saturation monitoring, with the frequency of assessments increasing based on the toxicity grade. Supportive care measures should be predefined, including orders for medications to reduce fever, intravenous fluids, oxygen therapy protocols, and safety precautions such as seizure prevention, fall, and aspiration risk management. Laboratory tests relevant to the condition should be ordered upon diagnosis and at serial intervals. These might include complete blood count, comprehensive metabolic panel, C-reactive protein, ferritin, and coagulation panels. Diagnostic imaging, such as head-computed tomography or magnetic resonance imaging, should be triggered for severe neurotoxicity. Pharmacotherapy forms the core of the order set, with pre-calculated, grade-specific medication orders. These should specify the medication, dosage, often based on patient weight, route of administration, and frequency, to minimize errors in calculation under pressure. Clear, automated triggers should be established for consultation with intensive care, neurology, and other relevant specialties based on toxicity severity or specific clinical findings. For Grade 1 CRS, nursing and monitoring include vital signs, VS, and neurological checks every 4 to 8 hours, with immediate notification to the MD for any deterioration. Supportive care involves acetaminophen 1,000 mg orally or intravenously every 6 to 8 hours as needed for a fever above 38 degrees Celsius, maintaining intravenous hydration, and, if neutropenic, obtaining blood cultures, and starting empiric broad-spectrum antibiotics per institutional protocol. No routine immunomodulatory therapy is indicated for Grade 1. Escalation criteria suggest considering management as Grade 2 if fever persists for more than 72 hours or if the patient has high-risk features such as comorbidities or rapid progression. For Grade 2 CRS, continuous cardiac telemetry and pulse oximetry are required, along with vital signs and neurological checks every 2 to 4 hours, and strict input-output monitoring. Supportive care includes the measures for Grade 1, plus administering intravenous fluid boluses, for example, 500 milliliters normal saline over 30 minutes, for hypotension, and providing low-flow nasal cannula to maintain SpO2 above 92%. First-line pharmacotherapy is tocilizumab 8 mg per kilogram intravenously, maximum 800 mg, over 1 hour. If no clinical improvement occurs within 8 hours, the tocilizumab dose may be repeated. If hypotension persists after 1 to 2 doses of tocilizumab and fluid boluses, dexamethasone 10 mg intravenously every 12 hours should be added. If increasing oxygen or hemodynamic support is required, management should escalate to Grade 3. Grade 3 CRS requires transfer to the ICU for continuous monitoring, with vital sign, VS, and neurological checks every 1 to 2 hours. Supportive care includes measures from previous grades, starting single-agent vasopressor support, for example, norepinephrine, to maintain a mean arterial pressure, MAP, above 65 mm of mercury, and providing high-flow oxygen support. First-line pharmacotherapy includes tocilizumab 8 mg per kilogram intravenous, if not already given, and dexamethasone 10 mg intravenously every 6 hours. If no improvement occurs, tocilizumab may be repeated every 8 hours for a maximum of 4 doses. If vasopressor or respiratory support needs to be escalated, management should progress to Grade 4. For Grade 4 CRS, ICU management and continuous monitoring are crucial. Supportive care includes previous measures, starting multi-agent vasopressor support, and providing positive pressure ventilation, invasive or non-invasive. Pharmacotherapy involves tocilizumab 8 mg per kilogram intravenous, if maximum doses are not reached, and methylprednisolone 1,000 mg intravenous daily for at least 3 days, followed by tapering. For refractory CRS, third-line agents such as anakinra or ciltuximab should be considered. This algorithm synthesizes recommendations from multiple guidelines. All medication orders require confirmation of institutional protocols and patient-specific factors. Tocilizumab may be repeated every 8 hours for a maximum of 4 doses per CRS episode. The management of ICANS differs from that of CRS, with corticosteroids as the main treatment. Tocilizumab is usually not recommended for isolated ICANS because it does not effectively cross the blood-brain barrier, and there is concern it might worsen neurotoxicity. For Grade 1 ICANS, nursing and monitoring include checking vital signs and neurostatus, with an ICE score every 4 hours. Supportive care involves seizure and fall precautions, reducing other sedating medications, and considering seizure prevention with levetiracetam 500 mg taken orally or intravenously every 12 hours. Routine immunomodulatory therapy is not usually recommended as the first treatment. Managing CRS depends on its grade, and tocilizumab can be given for CRS. For Grade 2 ICANS, nursing and monitoring include vital signs and neuro checks with an ICE score every 2 hours. Supportive care is similar, with the addition of keeping the patient in PO if there's concern about aspiration. First-line medication includes dexamethasone 10 mg intravenous every 6 hours, continued until ICANS improves to less than grade 1, then gradually tapered. If CRS is present, dexamethasone 10 mg intravenous every 6 hours should be started immediately, and tocilizumab 8 mg per kilogram intravenous may be given at the same time for CRS. For grade 3 ICANS, the patient should be transferred to the ICU for continuous monitoring and hourly neurochecks. Supportive care includes the measures above, along with an urgent neurology consult, and possibly a head CT or MRI to rule out brain swelling. Active seizures should be treated with intravenous benzodiazepines. First-line treatment involves dexamethasone 10 to 20 mg intravenous every 6 hours until ICANS improves to less than grade 1, then tapered. For CRS, dexamethasone 10 to 20 mg intravenous every 6 hours should be started immediately, with tocilizumab possibly given at the same time. For grade 4 ICANS, ICU care and continuous monitoring, possibly including ICP monitoring, are necessary. Supportive care involves airway protection, such as intubation, and measures to reduce brain swelling. First-line treatment is methylprednisolone 1,000 mg intravenous daily for at least 3 days, until ICANS improves to less than grade 1, then tapered. If CRS is present, methylprednisolone 1,000 mg intravenously daily should be started immediately, and tocilizumab may be given concurrently. This guideline combines recommendations from multiple sources. All medication orders should follow institutional protocols and consider patient-specific factors. Seizure prevention should be strongly considered for all ICANS patients. The simultaneous occurrence of significant CRS and ICANS presents a unique clinical challenge. A patient may show with grade 2 CRS, for example, fever and hypoxia, and also have grade 2 ICANS, for example, I-score of 5. A simplistic, isolated approach creates a paradox. The CRS protocol would call for tocilizumab, while the ICANS protocol would recommend corticosteroids. However, giving tocilizumab alone in this case is not advisable because it may worsen neurotoxicity. The guiding principle here is to start treatment that manages both syndromes, or at least does not worsen the more critical toxicity, which is usually the neurological decline. Therefore, the management process must include a key decision point. If a patient shows with ICANS of grade 2 or higher, corticosteroids should be started immediately, regardless of the CRS grade at the same time. Tocilizumab can and should still be used for CRS management, if grade 2, but it must be administered together with corticosteroids, not instead of them. This combined approach ensures prompt treatment of neurotoxicity while also controlling systemic inflammation that could be causing it. A subset of patients will have CRS or ICANS that persists or progresses despite optimal first-line therapy with tocilizumab and/or high-dose corticosteroids. Management of these refractory cases is challenging and relies on limited evidence, often from case series and institutional experience. Alternative cytokine blockade is considered a logical next step in managing refractory toxicities. Anakinra, an interleukin-1 receptor antagonist, has shown promise in case series for managing both refractory cytokine release syndrome and refractory immune effector cell-associated neurotoxicity syndrome. It is capable of crossing the blood-brain barrier, and a typical dose is 100 mg administered intravenously or subcutaneously every 6 to 8 hours. Cetuximab, an anti-interleukin-6 monoclonal antibody, can be considered for refractory cytokine release syndrome, especially if interleukin-6 levels are elevated. Unlike tocilizumab, which blocks the interleukin-6 receptor, cetuximab does not cross the blood-brain barrier and is not recommended for the management of immune effector cell-associated neurotoxicity syndrome. In severe, life-threatening cases that do not respond to standard treatments, other medications used to manage hyperinflammatory states include etoposide and ruxolitinib, which is a JK inhibitor. However, our experience with these agents is limited to case reports. Decisions to use such therapies should be made collaboratively within a multidisciplinary team, including critical care specialists and cellular therapy experts. The development of robust clinical guidelines and standardized order sets is a necessary but insufficient step toward ensuring the safety of patients receiving cellular therapies. The successful translation of these protocols from paper to practice requires a deliberate and sustained institutional commitment to education, system redesign, and the cultivation of a strong culture of safety. This final section provides key recommendations and a roadmap for the effective implementation of a comprehensive CGT toxicity management program. Key recommendations for clinical practice include adopting standardized grading and monitoring techniques, establishing specialized rapid response capabilities, implementing standardized order sets, and empowering patients and their families. All institutions administering cell therapy should formally adopt and integrate the American Society for Transplantation and Cellular Therapy consensus criteria for cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome into their clinical workflows and electronic health records. This involves mandating proactive monitoring protocols, such as conducting at least twice-daily immune cell evaluation score assessments for all at-risk inpatients. Institutions must also develop a specialized rapid response capability for toxicities related to cell therapy. This could involve creating a dedicated immuno-oncology emergency team or providing intensive, competency-based training to existing rapid response teams on the specific pathophysiology, assessment, and management of cytokine release syndrome and neurotoxicity syndrome. This team should be available around the clock. Implementing standardized order sets is essential. These should be developed, validated, and integrated into electronic health records for managing cytokine release syndrome and neurotoxicity syndrome based on severity. These order sets should serve as the default treatment pathway to ensure consistency and adherence to evidence-based practices. Finally, it is crucial to involve patients and their families in safety measures. Patients and their designated caregivers need to receive structured education before cell infusion regarding the early signs and symptoms of cytokine release syndrome and neurotoxicity syndrome. Healthcare institutions must also provide clear, straightforward mechanisms to allow patients and families to activate the rapid response team if they suspect clinical deterioration or feel their concerns are not being adequately addressed. The implementation of these complex protocols is a significant undertaking that requires a structured approach, guided by principles of quality improvement. The initiative must be championed by institutional leadership and led by a multidisciplinary implementation team. This team should include representatives from key stakeholder groups, oncology/cellular therapy physicians and advanced practice providers, critical care physicians, frontline ward and ICU nurses, clinical nurse educators, pharmacists, and quality and safety specialists. This collaborative structure ensures that the developed protocols are not only evidence-based, but also practical and tailored to the institution's specific workflows and resources. Education, training, and validation of competencies are crucial components of a comprehensive educational plan. All clinical staff involved in the care of chimeric antigen receptor T-cell therapy patients must undergo mandatory training. This training should cover the pathophysiology of cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. Staff should also be familiar with the correct application of the American Society for Transplantation and Cellular Therapy grading criteria and the immune effector cell scoring system. Additionally, training must include understanding the specific activation triggers for rapid response team activation related to these syndromes. Finally, personnel should be well-versed in the standardized management algorithms and order sets used in treating these conditions. Competency should not be assumed after a single educational session. Institutions should consider using high-fidelity simulation-based training to allow clinical teams to practice recognizing and managing these toxicities in a safe environment. Regular refresher training and competency checks are necessary to sustain knowledge and skills. The most well-designed protocol will fail if it is implemented within a dysfunctional clinical culture. The management of CRS and ICANS is a time-sensitive, high-stakes process that requires seamless communication and collaboration across multiple disciplines and levels of seniority. Institutional leadership must actively work to dismantle hierarchical barriers that can create delays in care. Bedside nurses, who are the first line of defense, must feel psychologically safe and fully empowered to activate the RRT based on established criteria or their own clinical concern, without fear of criticism or retribution. A culture where a nurse's call is met with respect and viewed as a critical safety check is a prerequisite for the success of any rapid response system. Implementation is not a one-time event, but an ongoing process of refinement. Institutions must establish a robust quality improvement (QI) framework to monitor the program's effectiveness and identify areas for improvement. This should be guided by the Plan Do Study Act (PDSA) cycle, a core tenet of healthcare improvement. The key components of this quality improvement loop include several interconnected steps. First, data tracking involves systematically monitoring crucial process and outcome metrics. These metrics may include rapid response team activation rates for clinical governance team patients, the time elapsed from trigger to treatment, transfer rates to the intensive care unit, and overall clinical outcomes. Second, post-event debriefs are conducted after every rapid response team activation involving a clinical governance team patient. These debriefs are structured discussions among all involved team members, aimed not at assigning blame, but at identifying systemic issues, communication breakdowns, or knowledge gaps. Addressing these issues often leads to process changes or targeted educational initiatives. Finally, the multidisciplinary implementation team should meet regularly to review the collected data and feedback gathered from debriefs. This ongoing review process helps utilize this information to continuously refine protocols and educational materials, ultimately enhancing patient care quality. Ultimately, an institution's ability to safely and effectively manage the acute toxicities of cellular therapy serves as a powerful indicator of its broader organizational health. It tests the strength of its interdisciplinary collaboration, the clarity of its communication pathways, and the depth of its commitment to a proactive culture of safety. Success in this domain is not merely the result of having a well-written protocol. It is the product of a highly functional, collaborative, and safety-conscious clinical environment. The effective management of cellular and gene therapy (CGT) toxicities hinges upon a standardized, protocol-driven approach rooted in a deep understanding of the unique syndromes they induce: cytokine release syndrome (CRS) and immune effector cell-associated neurotoxicity syndrome (ICANS). Foundational pathophysiology: cytokine release syndrome is an acute, systemic inflammatory response that occurs as a result of T-cell engagement. This engagement leads to the activation of other immune cells, primarily macrophages and monocytes. These activated myeloid cells are the main source of a massive, systemic release of cytokines. Among these cytokines, interleukin-6 is a central mediator and has been strongly associated with the severity of the disease. Neurotoxicity associated with this condition manifests as a distinct neuropsychiatric disorder called immune effector cell-associated neurotoxicity syndrome. It is frequently linked to the cytokine release syndrome, as systemic inflammation can disrupt the blood-brain barrier. This disruption allows inflammatory factors to enter the central nervous system and initiate a localized inflammatory response involving microglia, which results in neurotoxicity. Standardized assessment and surveillance are essential to guide therapeutic interventions. All clinical teams must utilize standardized grading criteria to ensure consistency and accuracy in patient evaluation. The grading of cytokine release syndrome is based on the most severe manifestation concerning fever, hypotension that requires vasopressors, and hypoxia that necessitates oxygen support, following the consensus criteria established by the American Society for Transplantation and Cellular Therapy. Fever is required for the initial diagnosis, but is not necessary for subsequent grading once anticytokine therapy has been initiated. Assessment of immune effector cell-associated neurotoxicity syndrome involves a multifaceted approach. A central component of this assessment is the immune effector cell-associated encephalopathy score, a 10-point cognitive evaluation tool. This score serves as a crucial, objective screening measure that must be administered proactively and conducted serially, at least twice daily. The purpose of these repeated assessments is to detect subtle cognitive declines, which are often the earliest signs of neurotoxicity related to immune effector cells. Rapid response and safety systems. proactive monitoring, and the American Society for Transplantation and Cellular Therapy grading system serve as the initial step in a specialized rapid response system. Activation criteria for the rapid response team should combine general physiological triggers, such as a systolic blood pressure below 90 millimeters of mercury, with specific signs related to particular syndromes. Examples of these signs include any new requirement for supplemental oxygen, which corresponds to a grading greater than 2 on the cytokine release syndrome scale, or a decline in the baseline immune effector cell-associated neurotoxicity syndrome score, indicated by a grading greater than 1. Institutions that administer cellular therapies need to establish a dedicated rapid response capability. This specialized system is necessary because general critical care responses are inadequate to address the underlying issues associated with these therapies. The management of these conditions is carried out through multidisciplinary standardized order sets to ensure the timely and consistent administration of immunomodulatory agents. For cytokine release syndrome, which is classified as grade 2 or higher, the first-line targeted therapy involves the use of tocilizumab, an interleukin-6 receptor blocker. In cases where there is persistent hypotension or hypoxia, classified as grade 3 or higher, corticosteroids such as dexamethasone are added to the treatment regimen. In the case of immune effector cell-associated neurotoxicity syndrome, when classified as grade 2 or higher, the primary treatment involves high-dose corticosteroids, such as dexamethasone administered at 10 milligrams intravenously every 6 hours. It is generally not recommended to use tocilizumab for isolated neurotoxicity because it does not cross the blood-brain barrier effectively and may worsen neurotoxicity. When patients present with neurotoxicity of grade 2 or higher alongside cytokine release syndrome, corticosteroids must be initiated immediately. This precaution is necessary even if tocilizumab is administered at the same time to manage the systemic cytokine release syndrome. For cases that do not respond to standard therapies, alternative agents such as anakinra, an interleukin-1 receptor antagonist capable of crossing the blood-brain barrier, may be considered for managing both cytokine release syndrome and neurotoxicity. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.